All right. Next slide, please. So I'm going to start by telling you about a patient that I met a little while ago. She's a new patient to me, a woman in her 50s. She has a history of PTSD, so post-traumatic stress disorder, depression, alcohol use disorder in remission. She has a high ACE score, so adverse childhood event score. She has experiences of racism. She has a prior failed serious suicide attempt. Initially, she had been managed and looked after by a psychiatrist who saw her along while I was seeing her for other conditions. And later, the psychiatrist was unable to continue following her. And so she presented to me for refill and management of her psychiatric medications. So I'm going to go through the list of her medications. I am going to read them out just to sort of highlight their doses. These doses are given as total daily doses. So quetiapine, 1,100 milligrams per day, zolpiclone, 15 milligrams per day, clonazepam, 1 milligram per day, gabapentin, 1,800 milligrams per day, escitalopram, 20 milligrams per day, bupropion XL, 300 milligrams per day, prazosin, 2 milligrams per day, rosuvastatin, 10 milligrams per day, and pantoprazole, 40 milligrams per day. Next slide. So what did she look like? How was she? So on clinical presentation, she was sedated, she had Parkinsonism, she had symptomatic orthostatic hypotension, so her blood pressure dropped when she stood up, and that even led to some falls. On her blood work, her cholesterol was high with an LDL up to 6.2, that's a bad cholesterol that's quite high, and a fasting glucose that fluctuated but was as high as 7.1. On her ECG, there was a prolonged QT, which puts her at risk for a fatal arrhythmia. Well, how was she doing? She, despite all this and all these medications, she continued to describe ongoing depressive symptoms, and her functional status was poor. She spent most of her time at home, isolated in her bed, rarely going out, rarely socializing, with minimal hobbies or activities. Next slide, please. So what are your thoughts? These were mine. Eeks! There's too many medications. The doses are too high. I'm really worried. I'm worried about drug interactions. I'm worried about side effects. I'm not sure what to do. I'm a family doctor, and I'm thinking all these medications were prescribed by her specialist for a reason. I'm worried. I'm wondering, should I decrease these doses? And what if I harm her by starting deprescribing? You know, currently she's not doing great. If I decrease these doses, is she going to do worse? And she shares my concern. She's really concerned that if I decrease any of her doses, that she is going to go to that dark place. And that's when she says that, she's referring to the time just before she attempted to kill herself. And I'm thinking, my goodness, I wish I had better access to psychiatrist support. Here in BC right now, we have inadequate access to psychiatrists. Next page, or next slide. So I very slowly, very carefully, trying to get her on board, started to decrease some of her medications. So I decreased her quetiapine slowly from 1,100 milligrams per day down to 900. I decreased her gabapentin from 1,800 slowly down to 600. And I did decrease and stop her prazosin. It was a big contributor to her falls. Next slide, please. I imagine my deprescribing journey with her to end up taking many months and years, but an opportunity came up. She was admitted to the hospital for an elective cardiac surgery in October. And this was not related to her mental health, and it was not related to her medications. And I got, I saw the consult come into my clinic that she'd been consulted by the psychiatrist, or seen by the psychiatrist in the hospital. So I had a thought, oh, maybe I can reach out and get some support for deprescribing. So I called the psychiatrist that was seeing her in the hospital, explained my concerns, and sort of put out a plea for help. Please, can you, maybe give me some guidance for a long schedule for deprescribing once she's discharged from hospital. And I'll hand it over to Dr. Gregson.
And next slide. Thank you, Dr. Norris. So I was asked to see her while she was still in the cardiac post-surgical care unit, which is an ICU environment. And when I went to see her, the intensivist was quite concerned about her psychotropic medications being a contributor to some challenges they were having in managing her post-operatively, particularly around sedation and somnolence. When I examined her, I found her to be hallucinating. She was very distractible. She was disoriented to time and place. Her speech was mumbled. She was sleepy. And I noted that she had an NG tube in place, which is sometimes relevant in terms of which medications we can give and how we can give them. The medication list is as noted, and I want to highlight the clonazepam dose, which had inadvertently been increased from the outpatient setting. So she was getting clonazepam 1 milligram BID rather than the 0.5 milligram BID that had been prescribed in the community, which may have been a factor in her somnolence. Next slide, please. So my diagnosis of her at that time was that she was experiencing a hypoactive delirium, likely multifactorial, as these delirium presentations often are, considering polypharmacy, her cardiac surgery, which would be a risk factor for delirium, and just being in the ICU environment where there's very little care to sleep-wake cycles, nighttime queuing for the environment. It's quite chaotic and loud all the time. I noted that she had a history of alcohol use disorder in full remission, which is important because alcohol withdrawal would have otherwise been a consideration, but not in this case. And then the previous diagnoses of both PTSD and depression. Next slide. So we, in consultation with the intensivist, made some very drastic reductions in the quetiapine from 900 a day to 150 milligrams a day, a morning dose and an evening dose, because we did want to manage anxiety during the daytime, didn't want to peel back all of that benefit she might be getting, but also wanted to get her a bit more wakeful so she could participate in postoperative care and mobilization. We reduced her clonazepam from the 1 milligram BID to 0.5, which is the outpatient dose. We did a big reduction in the gabapentin, considering that it may also be contributing to somnolence and sedation. And I made a decision to change the zopiclone from nightly to PRN because zopiclone is notoriously problematic in terms of delirium, particularly postoperatively. Next slide, please. So by postoperative day 6, and remember I saw her initially on postoperative day 2, she was clear in her mental state. So no longer experiencing any perceptual disturbance. She was oriented and attentive. There was no evidence of benzodiazepine withdrawal or Z drug withdrawal, despite the discontinuation of the zopiclone, which she was not receiving. There was no acute worsening in PTSD symptoms, and her mood was really quite stable. We spent some time talking about discharge, and she expressed anxiety about, well, what happens if I get worse when I go home? What if I can't sleep? And we reviewed how to manage these things that didn't include necessarily represcribing or increasing medication doses. And she was well enough for discharge home on postoperative day 8. With plan to follow up with Dr. Norris. I had offered her outpatient psychiatric follow-up, but she felt her alliance with Dr. Norris was very good and she preferred to see her alone. And I made myself available to Dr. Norris for ongoing telephone consultation and support. Next slide, please.
Okay, so I was meanwhile unaware of what Dr. Gregson was doing, and I got a notification at my clinic that she'd been discharged, and I hadn't yet seen a discharge medication list, a summary or a note from Dr. Gregson. So I felt a little disappointed and thinking, oh no, I'm going to have to go on this alone. And then a couple of days later, I saw the discharge medication list, and I actually, I think, giggled and smiled. I couldn't believe it. I looked, and her quetiapine was now at 150 milligrams per day, gabapentin all the way down to 200 milligrams per day, and her zopiclone had been stopped. She, of course, was on a few post-cardiac surgery medications, which I stopped as per the recommendations of her surgeons. Since then, I've been able to make a couple other changes. after a few weeks, she started to describe troubles with falling asleep. And so she was requesting to resume zopiclone or to increase her quetiapine at night. And I suggested that we actually decrease the bupropion, which can increase insomnia. So I decreased that from 300 down to 150. And a couple of weeks later, she reported that she was sleeping quite well. Back the couple of weeks before, I did add a melatonin there for what it was worth. I did also decrease her rosuvastatin and stopped her pantoprazole. Next slide, please. So most importantly, how is she doing? In those first few weeks, I was really quite astounded by the differences I saw in her. She was making jokes. She was talking about future plans, talking about wanting to move to be closer to family, talking about taking a course. She seemed to process and think more quickly. Like conversationally, it was just quicker. It is, yeah, the most future-oriented and engaged with life that I'd ever seen. Because of the decrease in the medication, she started to feel a lot more of her emotions. So these included the pleasant ones and the unpleasant ones. In the first few weeks after her surgery, she had her daughter and son-in-law stay with her, and she reported to me that she just really enjoyed the love and the connection and the companionship. And she was really sad that she hadn't had that in her life for so long, and that she didn't have it once they left. We had a lot of conversations about where she's at now and what's next for her. She was able to recognize, and these were her words, that she described that she had a prison, which was also her refuge of her medicated numbness and of her social isolation. And she had a choice whether to stay there or to kind of go through some of the challenges ahead into a place where she could have a more connected and engaged life. We both came to the recognition that the most important intervention at this point was human connection and activation. That's easier said than done. And so, yeah, in the last month or so, her mood has declined. She is having sort of more intrusive negative thoughts. And we're having conversations about, what do we do next? Do we try increasing just a teeny bit one of the doses, if that's going to enable her to make that human connection and activation? But it's not straightforward and not super easy. Next slide, please. I asked her, obviously she gave permission for us to talk about this today, and asked her what her sense of how this process was for her. She said that it's been good and bad, that when she first came home, she felt really happy with herself, like she could do this. She didn't need to be on all these meds. She didn't need to always be popping pills. She said that it felt like when she came off of alcohol and realized that she didn't need it anymore. She told me that her daughter noticed that she was more willing to be social. She wanted to come off all of the pills, but as the weeks have gone by, she began to feel, she reported that she was feeling more depressed and anxious. She says she wants to find a balance. She doesn't want to be over-medicated and sedated, but she doesn't want to be close to the edge of wanting to kill herself. She wants to find a dose where she can live each day to the most. And I also asked her, hey, we're doing this webinar. What do you want the participants to know? And she said, yeah, please let them know they don't need to give automatically huge doses. She also said you really need to know your patient. It's important to know who you're dealing with, what's important to them, and what their goals are. And she wanted to thank all of you for attending today, and was very appreciative that we're trying to figure out a way through this. Next slide. So these are my key learnings from this experience, and maybe some of these will resonate with you. So deprescribing requires trust, a lot of it. It requires a relationship and alignment with patient goals. I'd encourage you to look for opportunities to be deprescribed. I'm not sure if you'll each get this sort of miracle one that I had, but to look for ones that you can find. To anticipate both your and your patient's desire and impulse to restart those medications or re-increase those medications, and really look for other alternatives first. That complex regimens do definitely increase the risk of errors. I'd encourage you to notice when there might be a prescribing cascade that you can reverse. So we know about prescribing cascades where you add a medication to treat a side effect. Well, when we're decreasing medications, look for one that you can take away. To think about whether or not you and your patient are overvaluing the benefit that medications may be having, that often they are less beneficial than we think and more harmful than we think. And to note that, of course, high doses of antipsychotics or other medications can be really useful and helpful in certain situations, but continuing on at those high doses long term is likely to have increased risk of harm and may actually be a barrier to healing. Finally, medications can't fix loneliness. Next slide.
Thank you. And from my perspective, looking for the opportunities and when do they arise? When the patient asks, and so often when I see patients in consultation before we've even got them well, they're saying, when can I come off these medications, and want to think about that actually from the outset. And I would add when my colleagues ask for help in this area as well. If a patient's having side effects, right, nuisance, kind of predictable side effects or more serious adverse events related to medications, this is an opportunity. Polypharmacy, so multiple medications from the same class at high doses, this is a good chance to review what's going on. If the diagnosis changes, right, if we think we're treating a mood disorder and later find out it's more personality, then we want to refine our treatment, and that often includes deprescribing. Or anytime there's a change in the risk-benefit analysis for the particular patient in front of you around harms associated with the medication as they age or other more comorbidities arise, the medications may be causing more harm than benefit. So this is another chance to look at what am I doing here and can I make some changes? And that is the end of our formal presentation. And I'll turn it over to our moderator for questions.
Thanks, Alison.
Yeah.
So my name is Aaron Tajani. I'll be moderating questions that you've put in to the chat. And a reminder that to those streaming, if you send your comments and questions in by email, they'll be relayed to me as well. Excellent presentation, Jill and Alison, and some very interesting questions. Maybe I'll start with some background questions. One, do we know she was compliant in the community with that med list that you showed, Jill? And second, was she receiving any sedating or psychotropic meds in hospital for pain or associated symptoms?
So I can answer the first question. Yeah, she was getting weekly blister packs, and her community pharmacist was monitoring that closely.
Great.
Yes, and so postoperatively, yes, there would have been pain medications, opiates on board most commonly, and then often there's IV sedation as well in the form of various infusions. I'm not an anesthetist, and that's who manages these patients in the postoperative period, but they use a variety of agents.
Okay, thank you. And maybe I'll ask my question. Jill, you started with deprescribing and you picked 2 drugs. Can you explain what made you choose those drugs? And how quickly or slowly why did your plan come out as it did?
Yeah, I picked the quetiapine because I was quite worried about the QT, the changes on the ECG, and that she was sedated, and it just was such a high sort of out of normal range dose for what her diagnosis was. And then I went very slowly because she was quite hesitant, and it wasn't as though she'd been perfectly even and stable prior to me trying to deprescribe. So she was always struggling. So I just decreased by 25 milligrams, or depending, every few weeks, or by 100 depending what was going on. So this took some time, and sometimes when I'd even have a locum, they might get bumped back up, and then you had to sort of resume. The prazosin was an easier one to do because of those falls, and right away she felt better with decreasing that. And interestingly, she was able to get a sorry, I'm blanking on it, but a support animal that really helps her with her nightmares. So the dog will come and be with her, and so she's not having the horrible nightmares anymore, or terrors. She has the support for that when they happen.
Okay, thank you. And I guess a related question, did this patient have community supports or any other supports that assisted in the process? And you mentioned the dog, but were there other tools in place?
Initially, when I met her, she had a mental health nurse that would accompany her to appointments. And then for some reason, the funding got lost there. She would occasionally see a counselor, but then the pandemic happened. It's been quite tricky to find supports, and then also for her to engage in them, because that's hard for her to do. And that's what we're negotiating right now. And the community pharmacist was super helpful.
Okay, thanks, Jill. Alison, is this kind of aggressive deprescribing intended for shorter term interventions, or is it because of the institutional setting that the plan you two adopted progressed so well and maybe quickly? What if they didn't have the extra supports or resources available?
Yes, and Dr. Norris and I have discussed this. It's somewhat easier to do this in a pretty aggressive fashion in the hospital for a couple of reasons. One is people are monitored very closely. I can see them every day. And so if we kind of estimate how much they can tolerate the reductions, I also have the ability to kind of course correct fairly quickly, particularly around things like benzodiazepines, where there is a potential withdrawal syndrome that can be very uncomfortable. So I can adjust that more quickly. I must say, when I did the deprescribing in the CVU or ICU setting, it wasn't intended to be a forever thing. It was intended to address the acute concern of somnolence largely and get her moving. But it turned out to be a fortuitous opportunity to achieve a longer term goal.
Okay, excellent. Thank you. And again, they're all related questions, but there presumably there must be some risks that you're watching out for either the slow taper or a more aggressive taper. What did you two have in mind that you were specifically looking for as the doses came down?
For me, with this particular medication regime, the two major things would be benzodiazepine withdrawal, which is both uncomfortable and can contribute to delirium in and of itself, or potentially seizures, right? As we rapidly reduce gabapentin and or benzodiazepines. In principle, I don't tend to see those as major consequences unless we've abruptly stopped everything.
Okay. Jill?
Yeah, I think for me, what I'm primarily looking for is declining mood and increasing suicidality, self-harm.
Okay. And I know one of my colleagues had suggested considering the elimination half-life of drugs, and the time it would take to clear the drug, and if you're considering a quick decrease in dose or an abrupt stop, that can be used to be the marker for when early withdrawal might be seen. Is that something that you incorporate in your plan?
Yeah, absolutely. Half-life matters. And so sometimes if I see people on short half-life benzodiazepines in particular, I'll switch them to a longer half-life benzo to smooth the withdrawal curve and make it much easier for them to tolerate.
Okay, thanks. And one interesting question that's come up in other presentations at the TI is about the communication between community clinicians and hospital clinicians. So it seemed, Alison and Jill, that you work very closely and well together. How did you structure that communication, and how was that relationship so good?
I credit Jill.
I was desperate, and she was lovely and open and got the concerns. So I think that was someone who's a consultant that's on board with this idea. It was really helpful. I would just say it was interesting. There's a bit of a delay when I got the discharge medication list, and then there's a further complication that happened is that the medications accidentally got sent to not her regular pharmacy, and so she got huge amounts of clonazepam and all these medications in one go, when previously she'd been on weekly dispensing or every 2 weeks. So her community pharmacist really stepped up there and was able to go to their house, get the other medications, package them and give them back to her in a safe way and monitor. So we had a few conversations there, so that was helpful.
Okay, thanks. And I think, Tom, if I could ask one more question. Someone's asking about why the rosuvastatin was reduced, and if you can give some background on the cardiac condition she was having treated.
Yeah, so initially her, prior to her being on the high doses of the quetiapine, she had a normal cholesterol or lipid panel. It increased, and when it kind of got to that level, I did start her on rosuvastatin, was at 6, and then she didn't have any coronary artery disease, she didn't have any stroke, so she didn't have any indication for primary prevention. So once the dose was down of the quetiapine, I stopped the rosuvastatin. I don't think it was going to give her help. And I'm waiting for, she's going to do the blood work, but I'm assuming that's going to be a lot better.
Okay. Alison and Jill, thank you so much for answering the questions. For those in the audience, I'm sorry I didn't get to all of them. We're going to save the chat and questions, and time permitting, Jill and Alison may be able to provide some responses that we'll find a way to post on our website or communicate to you in some other way. So Tom, I think I'll turn it over to you.
Hi again, everyone. Thank you very much, Jill and Alison. And for people who might consider wanting to present in future in these rounds, I think you're all aware that we invite submissions. You can see that was a beautiful example, and I think you're going to see another of how to do it. Very challenging to do it in such a short time. And one might want to look back at that again once it's posted to try to figure out how they managed to do it in 15 minutes. Now, I'm pleased to introduce Cameron Bonell, who's a very experienced pharmacist from the interior of British Columbia in Kelowna. He's now working as a primary care network pharmacist, which is a new government of BC initiative to provide specialized pharmacy consulting on referral from family doctors and nurse practitioners, and I guess even from patients or families. So take it away, Cameron. He's got a very challenging case, and we'll try to get a few questions once he's finished.
Thanks a lot, Tom. I'm a pharmacist, and I'm hoping Dr. Gregson's going to stick around so she can maybe give us 2 bits on this case as well, because it's quite a challenging one. So I'm just going to go to this slide here and let you guys digest this medication list on the right, and the comments or the reason for referral from the family practitioner on the left. So as Dr. Perry mentioned, I am a primary care clinical pharmacist. So I don't dispense medications any longer. I strictly work as a referral for primary care physicians to try and help with any questions that they may have and concerns that they may have with medication changes or options. If you don't work with a primary care clinical pharmacist, or you don't have one, I really recommend you touching base with your community pharmacy, especially if you have a patient who's commonly seeing that pharmacy regularly, or is on blister packs, because that tends to be a very good interaction to foster. So this patient was referred for med review, and polypharmacy was basically what the family doctor was describing. I'm just going to highlight a couple of the medications on this list that jump out at me as a pharmacist. I'm looking to see things that may be a little bit of a red flag. And you can see there's a lot of medications on this list that are CNS depressants. At bedtime, she's got some benztropine, big dose of hydroxyzine, and a couple of sedatives. So a pretty good dose of temazepam and also some zopiclone. So that's kind of my starting point where I'm looking at drugs that I might be concerned about. As a pharmacist, I typically work in a little bit of a information vacuum sometimes, and I'm sure the community pharmacist can really recommend to that, or really relate to that. I have a little bit more information and the lab data and some reports and stuff that they may not have. So if you're doing a referral as a family physician to your community pharmacist, the best thing you can do is have a little conversation with them, even a couple of minutes on the phone, to explain what your concerns are, rather than having them trying to piece together things bit by bit. So this patient here, a relatively young lady, under 40, history of major depression. She has had ECT therapy in the past, last time a couple of years ago, and she was hospitalized in early 2022 for depression with suicidal ideation. Followed into hospital by psychiatry with a plan for follow-up in the 6 to 12 month range as an outpatient, and then daily management or outgoing management with her family physician. The family physician is dealing with some complaints right now, principally daily headaches and attention span difficulties. So when I dug into this a bit more, I found that she was actually also referred through to neurology for these complaints. So daily chronic headaches and reduced mental acuity, daytime sedation. So I noticed that the neurologist had actually responded back to the family doctor asking that the medications be reviewed on this patient to see if there was any contributing factors for these complaints. He also wanted to screen for some drug interactions for some medications. He was considering potentially valproic acid or topiramate as a headache prophylaxis, so he wanted to make sure there was no problems with drug interactions. Now, as a pharmacist, what I've found over the years is my best source of information and my best source of being an ally is the patient. If I don't get buy-in early on with a deprescribing journey, it's going to be an uphill battle the whole way. So these are kind of the three questions that I really ask patients right from the get-go. I want to know if they think there's any medications that are causing problems for them. And I want to know if they think there's any medications that they feel are unnecessary. And then I really want to focus on what their biggest concern is. That might be their biggest concern with what the medications are doing for them, or their biggest concern with what I'm going to do with their medications. So that's kind of the starting point with deprescribing when I'm talking to a patient like this. So when I initially saw this patient, she amazingly didn't really attribute any of her effects, any of her adverse effects to the medications. She highlighted that methylphenidate had been started a few months before, but she didn't really think it was working and was wanting to stop it. And she really wanted me to not touch any of her sleeping medication. She had been a couple of weeks without sleep in the hospital when she was in the hospital a few months previous, and did not want to get back to not sleeping. This assembly of sedative medications was put together to get her to sleep in the hospital. Her biggest problems, or the things she was kind of focused on at this stage, were attention and memory issues, and this chronic daily headache that she described that accompanied with some mild to moderate nausea. When she came to her appointment, she was on time. She was appropriately dressed. She was a bit slurring with her speech, and she was easily distractible, had to collect her thoughts while we talked. But she was a pretty good historian as far as what the medications were being prescribed for and what she thought they were doing for her. The most recent medications added after her hospital discharge were the methylphenidate for attention issues, and then a declining mood in June prompted the initiation of bupropion, and subsequently pantoprazole, which was again increased in August. So from her actual comments, she really was not able to wake up in the morning. I think she said she was hitting her snooze alarm 6 or 8 times in the morning. She wasn't able to think straight and felt that she could fall asleep pretty much any time during the day. The one thing that was really interesting, or really kind of highlighted from her, is that she was home to see her mother relatively recently, and she scared her mom when she was found to be up and wandering about incoherently about 30 or 40 minutes after her nighttime medications. And the only thing that she would respond with was that she was getting snacks. So I kind of dug into that a little bit, because I know the Z drugs in particular are associated with these nighttime excursions. Also higher dose benzodiazepines, or patients who have alcohol with those sedatives. Incidentally, she does not drink alcohol. So she said that she does often find that she wakes up in bed with food wrappers or food remnants in her bed with her and no real recollection of eating. So to echo Dr. Norris's concerns, my first concern would be EECs. There's too many drugs, doses are too high. I'm really concerned about destabilizing this patient if we start reducing medications rapidly. She's scared that she's gonna have problems sleeping if I touch any of her sleeping medication. I'm also interested in whether the psychiatrist and the family doctor and the patient are on the same page. And by that, I mean, this is kind of a place where the pharmacist ends up being in a little bit of a squeeze play here, because they may be checking, this patient was on blister packs, checking blister packs for a patient, and they're alarmed with all of these sedative medications. I can remember doing this myself and thinking, how is this person functioning with all of these sedatives? You know, it's easy to be an armchair prescriber in that scenario. It's much more difficult when you're actually dealing with the patient, trying to figure out which medications to adjust and which medications maybe not necessarily to be continued. And I know the family doctor was uncomfortable with this group of medications. That's one of the primary reasons he wanted me to have a look at it before kind of consulting with the psychiatrist about what could be done. Also, the neurologist wanted to document and predict any drug interactions if he was going to add any additional medications. So being a good pharmacist, I want to make sure I look at all the drug interactions. So I've simplified the drug interactions that come up from a lexicomp search here. I know you guys are not going to be able to really read this, but basically the worst interactions are at the top, and then the less intense interactions are below that. Simplified by saying anything in red here has an interaction with it. So you can see there's really interactions with everything. Mostly these interactions have to do with additive CNS depression. So, and when it comes to the orange interactions at the top here, which are the ones we're more concerned with, it's the vortioxetine and bupropion interaction that kind of caught my attention the most. Again, you won't really be able to read this, but the biggest interaction, or the main interaction here, is that bupropion is metabolized through the cytochrome P452D6, and it acts as an inhibitor of that enzyme, which is the primary enzyme for metabolizing vortioxetine as well. So we often would see in these studies a doubling of AUC or a doubling of Cmax when bupropion is added to vortioxetine therapy. She's taking 20 milligrams of vortioxetine, which is considered to be the top dose. So really, she might be being exposed to more like 30 or 40 milligrams of the medication. The main side effects with this would be that showed up in these studies were headache, nausea, and vomiting when this combination is together. So that's interesting in and of itself. So my first thought here is, well, we should get rid of this bupropion. And she didn't want to touch the bupropion. She actually found that since it had been added, she felt better, and her mood was improved beyond any previous medications. So then that brings me to my first recommendations to the family doctor. And I said, you know, in consultation with the psychiatrist, you should consider reducing the vortioxetine to 10 milligrams. The patient was concerned about this when I mentioned that this might be one of the plans we would look at, and she was concerned about her mood being not necessarily as supportive with a lower dose. So it would be a potential to increase the bupropion to a 300 milligram dose after a couple of weeks. Very long half-life vortioxetine, probably 2 weeks at least before you see a new steady state with a dose reduction. So at that time, it might be an appropriate time to try a higher dose if it looks like she needs more mood support. Recommended stopping the methylphenidate. The methylphenidate, very short half-life stimulant, probably could just stop it, but I did recommend to the physician, if he was concerned of doing that rapidly, try a half dose initially. I didn't really think this patient needed to be on the additional CNS depressants, but if valproate or topiramate were to be added by the neurologist, there weren't actually any strong interactions of concern other than additional sedation. And then I had listed out a number of considerations for tapering of quetiapine, benztropine, hydroxyzine, zopiclone, and temazepam, obviously, hopefully not all at once, but in a stepwise fashion. My kind of thought process with this was hydroxyzine might be the easiest one to start with reduction, And I know these medications like benztropine and hydroxyzine that have very strong anticholinergic effects also have very strong effects on cognition. So that was my first thought. So the family physician initially reduced the hydroxyzine to 25 milligrams. He did a little reduction on the quetiapine as well, to 300. And we suggested to reduce the benztropine down to once a day, and he reduced the methylphenidate down to half the dose. So I followed up with this patient again 2 weeks later to see how it was going. She was happy with this 300 milligram dose of quetiapine, hadn't really noticed any change or issues with that. She had not really wanted to reduce the benztropine, however, because she felt that she was getting tics during the day when she only had 1 milligram of the benztropine. So she'd gone back to taking it twice a day. She didn't think she was able to sleep at all on 25 milligrams of hydroxyzine, and it was increased back to 50 milligrams. And she says she didn't function well on methylphenidate, lower dose. So it was back to 36 milligrams. Hard to say exactly what her description was here for not functioning well, but at any rate, she didn't want to go back down to a lower dose or stop that medication. So I think one thing I was going to mention with this case is it's not really a classic case of deprescribing success, but it does have some very interesting surprises. When I followed up with her again in 2 weeks, and my principal reason for following up is that we were trying to get this benztropine dose down to 1 milligram a day. And so I wanted to see how that had gone for her after a couple more weeks. And at that follow-up, she had had a very frightening episode. She had been visiting relatives and was wandering around the house incoherent and unresponsive in the evening. She was told she looked like a zombie, and the children that lived in the house were terrified. So this scared her. She was absolutely frightened by this. I think her relatives had told her she wasn't going to be able to sleep over at the house again if she did this. So she abruptly stopped the temazepam and zopiclone cold turkey. So when I saw her, it was about 6 days after stopping those medications. Interestingly, she didn't have any irritability, anxiety, agitation, or worsening mood. So those are kind of the benzodiazepine withdrawals or the risk for a seizure threshold being reduced. And she only complained of mild sleep latency. So she said it took a little longer to get to sleep, but when she got to sleep, she was sleeping fine. So that's quite surprising. Now, 6 days half-life of zopiclone and temazepam in a younger adult is kind of in the 5 to 10 hour range. So she's by 6 days, all of that medication is out of her system. So I followed up again with her 7 weeks after this cold turkey event, and she remained off the temazepam and zopiclone, and she had successfully reduced the benztropine to 1 milligram a day. So as a summary on what her medication looks like in January versus September, the big changes, of course, are these sedatives, which she stopped on her own, and then we have little changes in the benztropine and quetiapine doses. My next discussion was actually a phone appointment as opposed to in person. So not quite as good of a way to determine some of those cognition or how she's looking, those nonverbal cues. But she did seem to be considerably more engaged. There wasn't that slurring that we noticed before. She was still complaining of daily headaches. Interesting with her headaches, she wasn't really using any medications for the headaches, occasionally taking Tylenol, but mostly dealing with non-drug measures. She had lost her job in the fall, which she actually attributed to being the main reason why her stress was lower and why her headaches were less pronounced. And then she told me that she had lost 40 pounds intentionally since October. So that was a little bit of a red flag for me. I wanted to make sure that the family doctor was aware of this, just to make sure we were screening for any kind of eating disorders or other causes of rapid weight loss. But it also made me wonder about how much she was eating in the middle of the night with her previous regimen. Perhaps she was eating large numbers of calories every night and not really being aware of it. And then she was complaining of a new symptom of being clumsy, bumping into walls and dropping things and knocking over lamps and stuff. So that was a little bit concerning as well. So my next recommendations was I still wanted them to look at this vortioxetine dose. The headaches and nausea could potentially be that interaction with the bupropion. So I wanted to discuss that further. I'd also like to see a continuation on the quetiapine taper. Prior to her hospitalization the year before, she had been on 150 milligrams of quetiapine, mainly as a sedative. And, so she was on double that dose. Now it'll be interesting to see if that could be further reduced. Lithium, the lithium level was done in 2022, and it was on the low end of therapeutic. She does have some issues with elevated serum creatinine for the last few years. So I think it would be wise to repeat the lithium level, since she's about 20% less heavy than she was before. And then some other minor changes I had recommended as well. So what surprised me with this case? Well, it surprised me that she was able to stop these sedatives abruptly with no apparent problems. And I guess I had assumed that this was going to be a big battle to get these benzodiazepine, temazepam, and zopiclone off of her medication list. And I actually had prepared a 4 to 6 month tapering plan for her. Because I guess it's a bit of my own bias, because I have numerous patients in the past that have difficult times getting off of these medications. So I guess if the patient is strongly motivated, they may be able to go off of these medications. And of course, abrupt cessation is really not ideal with these medications, but it seemed to work for this patient. So we mentioned, I discussed with her about us talking about this case. She wanted to make sure we knew that she was really excited that we were going to be talking to each other about this, and that we were going to be willing to learn about how to adjust people's medications so that they function better. And she just wanted to make sure we know that people kind of get stuck on medications and they feel like it's never going to change. So even if changes seem hard to begin with, you should try and get there. So what kind of key learnings can I have as a takeaway for deprescribing from this? And this is really kind of the first 5 things in particular are the things that I bring up with patients on a regular basis when I'm consulted for deprescribing and for polypharmacy. Is I really want to focus on 1 and 2 initially. So that being, what is the patient concerned about? If we can get patient buy-in early on, we can build on those successes later. And 2, just explaining to them what kind of risks that I'm concerned about with high doses or with combinations of medications that they might be posing to them. Drugs that are not beneficial or unlikely to be beneficial are often easy things to get rid of from a point of view, from a therapeutics point of view. So stuff like supplements and some herbal products. Discussing how to get rid of those things is beneficial, even from a monetary point of view for patients. And then looking at duplications, can you eliminate duplications? Drugs that do the same thing, but really aren't rational to be necessarily combined together. And are the doses the patient on, are those rational? We have guidelines and dose ranges for a specific reason. Now, keeping that in mind, that these are heterogeneous populations, and people don't always respond the same way to medications. But if you're going way beyond what the guidelines suggest for an upper limit of doses, there probably should be a good reason for it. The last thing, and this is kind of the key point on this type of medication list, is were drugs added at a time when the patient was in crisis that were necessary at that time, but can now be looked at as targets for cautious deprescribing. And that may not necessarily even be for psychiatry medications, but even medications for like, COPD or for CHF or things that get added on when the patient is in crisis in hospital, and then maybe continued afterwards at doses or combinations that aren't necessary. So I think I'll leave that there and see if we have any comments, and get back to you, Dr. Perry.
Yeah, thanks, Cam. That was an excellent presentation, and there's a flurry of questions and comments. So it'll be rapid fire. I hope you're ready, Cam. Just to give you a chance to have a sip of water, a reminder to participants, if you're interested in receiving continuing education credits, we'll be sending you an email with an evaluation form. If you complete the evaluation form and send it back to us, shortly after, we'll be sending you an email with a certificate so you can claim those credits. So feel free to utilize that opportunity. So one comment first that bupropion is amphetamine-like in its pharmacology, and combinations with methylphenidate can be problematic. So that's just as an FYI. And also another comment about the benzodiazepine withdrawal. And Dr. Gregson had suggested that very, very slow tapers are used by her in some cases through liquid formulation. So you could do microdosing. But in most cases, she feels that a 10% reduction per week can deal with many patients. So one question, is her waking up without recollection associated with her medications or illness?
Yeah, and that's a good question. That was kind of one of the initial things we talked about. Was she did attribute some of her cognitive problems with previous ECT therapy, but you know, it's pretty common for adding all of these medications together, particularly at high doses. And we know for sure with the Zopiclone and other Z drugs that decline in short-term memory can be quite pronounced. And I often see patients, especially patients on high doses of the Z drugs, who have these nighttime excursions or can't figure out who's eating all the food in their fridge. So I really like initially to, until proven otherwise, think it's the medications.
Okay, thanks, Cam. A couple of comments about the plan, and I know you said it wasn't ideal to do so many things at once, but how do you determine what change is leading to what improvement, or any guidance on that?
Well, and I'm not the expert in this. It's the patient that you're doing the deprescribing for that's the real expert, because they're the ones that are going to have to implement your plan. So if you can have a plan that they buy into, that's the first thing. The other thing I tend to find is that people are very protective of their benzodiazepines, and they're very protective of their Zopiclone. So my thought was that hydroxyzine might be a good first target. Turns out that was completely opposite from what her experience was. So interesting. And I know the other thing is that, and this is one of the problems, I guess, when you're dealing with the family doctor's dealing with prescriptions that were initiated by the psychiatrist, but he's having to deal with ongoing daily concerns from the patient. But he may be feeling uncomfortable with reducing medications that were initiated by the psychiatrist as well. So I think he was more comfortable with a cautious reduction of quetiapine and a reduction in hydroxyzine dose rather than touching the other sedatives first. So,
okay, great, thanks. Some questions around the acetaminophen and how frequently the patient was using it. One suggestion, instead of using other drugs for headache, maybe stopping the acetaminophen. But any
she was
insight
actually
into
she was taking very, very little acetaminophen. She was mostly dealing with her headaches with a cold pack, a darkened room, and having a nap. And she was only taking a couple of doses of acetaminophen a week, like maybe 2 to 4 doses per week. Occasionally, she was also taking naproxen, although she had been warned to not do this because her creatinine had been elevated for the last couple of years.
Okay. An interesting comment. Someone says, I found the combination of Zopiclone with quetiapine to be particularly prone to sleep eating, complex sleep behaviors with Zopiclone, plus increased appetite with quetiapine. So that may be it. And then another question.
I found that for sure with combining Zopiclone with other sedatives in general. Biggest one I've seen is people who have a nightcap with their Zopiclone and then end up having night excursions.
Someone says they're experiencing side effects just looking at your case. So I hope you recover soon. A comment about the serotonin syndrome and as an explanation of the clumsiness. And Dr. Gregson had said that that's a possibility. And
that was one of the things I mentioned was I was concerned about serotoninergic excess with the methylphenidate and the vortioxetine bupropion, all potentially having issues in that. So that was another reason why I still thought they should be looking at the vortioxetine dose.
Okay, thanks. A couple of FYI points. Dr. McCracken has an EMR template for deprescribing. She shared the link if you want to look at that. And a colleague of ours, Kate O'Sullivan, had reminded us that if you look at all the evidence about bupropion and dose response, there's very little evidence to suggest there is a dose response for depressive symptoms. So keep that in mind. Lots of interesting comments. Our clients, our clients with persistent and very severe mental illness who end up with clozapine and its associated meds are told that the meds are better and given the impression that a severe episode could affect their brain and thus the meds are better. I'm curious about what this is in reference to. In my experience, very few people end up on clozapine without a lot of thought. These are amongst the most severely ill patients in psychiatry, and the risk of recurrence is high without clozapine. Any comments on that?
That was actually my comment, just somebody asking about clozapine. I very rarely would I kind of muck around with somebody being on clozapine without a very, very compelling history to suggest it was safe. People who end up on clozapine, they have severe refractory illness, often history of suicidality and violence. And
I see we have 2 more minutes, so I'll just ask one question, maybe to any one of the presenters. How can some of these polypharmacy issues be stemmed from the beginning? Like, do you have any, maybe that's a tough question to end with, but if you have any last minute thoughts before we wrap up, that would be great.
I would have some thoughts. I think I noted Josh said something in the chat about having good primary care, having time to spend with patients where you can address some of the root causes, having access to funded psychology so that we're not grabbing for a prescription pad.
Okay, thanks, Jill.
Yeah, mine is have a plan. So if I'm adding a drug, what am I planning to take away in its place? And reminding the patient that we had agreed to do that, right? Because they get to equilibrium, they don't want to make any changes, but always reminding the patient that, you know, the goal is less.
Okay. Okay, thank you so much. Tom, I'll turn it over to you to wrap up.